For a case of shoulder or arm pain, using our mnemonic old cards, we'll note the onset, or when did your pain begin. Did it come on suddenly, or was it more gradual? And do you remember what you were doing at the time? For the location, we'll ask our patient to point with one finger. For the duration, we want to know if your pain has been constant since it started, or is it more intermittent. If that's the case, we'd like to note the frequency. That is, how long does an episode of your pain last for, and how many episodes have you been having per day or per week? Next, we can note the progression. Does your pain appear to be occurring more frequently or more severely? Or if there has been no progression, we'll also want to state that in our patient note to show that we've asked. To help characterize the pain, we like some descriptors, sharp or dull among others, and since this can involve the nerves as we'll see below, we'll ask about any numbness, tingling, or motor weakness. Aggravating and alleviating factors, radiation, treatments tried, and severity on a scale of 1 to 10. And again, if there are no aggravating and alleviating factors or radiation, we'll also state that in our patient note to show that we've asked. We'll break down a case of shoulder pain into trauma or atraumatic cases. For all cases, let's order a CBC, serum electrolytes, an x-ray of the right or left shoulder, and if we have any neuropathy, as we'll see above, a nerve conduction study and an electromyogram. In a shoulder dislocation, our supporting points will include shoulder pain, an onset that's after a fall or trauma. It can be aggravated by movement and alleviated in the sling or rest position, and we'll note a decreased range of motion in our physical exam, as we'll see coming up. In a shoulder or humeral head fracture, we'll see arm pain, and again, after suddenly with a fall or trauma, and if the fracture is severe enough, we could note a neuropathy, or numbness, tingling, or motor weakness. It will be aggravated by movement, and we'll find limited relief by conservative management from the underlying fracture. We'll also see a decreased range of motion in our physical exam coming up. In a clavicle fracture, we'll see shoulder pain, an onset again that's suddenly after a fall or trauma, and aggravated by movement, and now radiating to the clavicle with limited relief by conservative management. In osteoarthritis or degenerative joint disease, we'll see shoulder pain that now is an onset that's more gradual, but progressively worsens. And classically, it's characterized as dull or achy and aggravated with use and alleviated with rest, and it is typically seen in an older patient greater than 50 years old. It is also important in high yield to consider the neck as a source of referred pain in any case of an upper extremity pain. In cervical radiculopathy, we'll note a history of neck pain, and we could see or reproduce a radiculopathy or unilateral radiating pain. Biceps tendinitis, the chronic form, or in a tear, the acute form, will have now anterior shoulder pain. The onset will be after heavy use or prior rotator cuff injuries in the chronic form, or acutely after a trauma with a characteristic popping sound. It can be aggravated by carrying or lifting and radiating distally over the biceps. We'll have a positive speeds test, and we'll add to our workup an ultrasound of the right or left shoulder. In adhesive capsulitis or frozen shoulder, we'll see shoulder pain, and now with stiffness, can be described by our patient as I can't move it like I used to, or a decreased range of motion. It will be aggravated by overhead activities or at night from sleeping on the shoulder. Our patient is typically older with a history of diabetes, immobilization, or prior injuries. In a rotator cuff impingement or tendinopathy, the pathology here is the rotator cuff tendons becoming impinged or inflamed from the tight space between the humerus and acromion. So we'll see a shoulder pain, possibly weakness, and it will be aggravated by overhead activities that further compress the tendons in the tight space between the humerus and acromion, or at night from sleeping on the shoulder, and it will be alleviated by conservative management. And we could see a positive special test noted in our physical exam, empty can, Neer, or Hawken, and we'll add to our workup an MRI of the right or left shoulder. In a rotator cuff tear, we'll have shoulder pain and now with weakness, as we'll see in our physical exam, including decreased abduction. The onset will be after trauma if in the young, or very interestingly and high yield if in the older patient, more gradual pain or with prior episodes of impingement. So we don't need to have a trauma in an older patient, and it will be aggravated by overhead activities. We'll see a positive empty can, Neer, Hawken, and now drop arm test in our physical exam. In rheumatoid arthritis, we'll see shoulder pain and will be aggravated in the morning, high yield morning stiffness, and alleviated with use, will have additional bilateral small joint arthritis, including in the wrists or fingers, and now systemic symptoms noted in our review of symptoms, including fatigue, fever, and weight loss. We could also note a positive family history. We'll order ESR-CRP, rheumatoid factor, and anti-CCP antibodies. In systemic lupus erythematosus, we'll see shoulder pain, malar rash, oral ulcers. Our patient can be complaining of photosensitivity or Raynaud's, blue fingers in the cold or during times of stress. And we could also note the systemic symptoms in our review of symptoms, including fever, weight loss, or fatigue, and also a history of abortions in the OB history. And we'll order ESR-CRP, an ANA, anti-double-stranded DNA antibodies, and anti-Smith antibodies. In crystal arthritis, we'll have shoulder pain and now with erythema, warmth, or swelling noted in the inspection or palpation. For gout, we'll also see podagra, or episodes in the big toe, or tophi with crystal deposits in the ear or Achilles. And we can note a history of heavy alcohol use or red meat. In pseudogout, the patient is typically older, greater than 50 years old. And we'll order ESR-CRP, arthrocentesis for gram stain, culture, and microscopy, and a serum uric acid. And finally, in septic arthritis, we'll see shoulder pain, and again with a fever, erythema, warmth, or swelling. And in gonococcal, commonly in the female because they're asymptomatic gonococcal carriers, we'll have a characteristic pustular rash with a history of STDs. Or in the non-gonococcal form, from Staph aureus or strep, we'll have a history of skin trauma, abrasions or cuts, diabetes, or IV drug use. And we'll add here blood cultures.
I have my hand sanitizer here. I'm going to put some in and rub. I don't want to touch my patient until my hands are fully dry. I don't risk getting some in his eyes. Okay, so, and this is the time where you're going to greet the patient. Good morning. Introduce yourself, find out the patient's name, and, engage in some small talk. That's fine. So, my hands are dry, and it's time to start. So, Mr. Heskowitz, you mentioned during the history taking that you had shoulder pain, right?
Yes.
Your right or your left side?
My right.
Okay. So I'm going to do shoulder examination. I usually go through an algorithm: inspection, palpation, range of motion, muscle strength, sensation, reflexes, and pulses, at least for the basics, and I take it from there. So right now he told me he had pain in his right shoulder, and I'm inspecting now. Okay. All right, so I've inspected. There's no redness, no swelling anywhere. Okay, no visible lesions. And now it's time to palpate. So I'm going to palpate around the front, top of it, where the acromion process is, behind. Do you feel any pain?
Yes, right there when you press.
Right here.
Yes.
Okay, sorry about that. I'll be more careful with that area. And over the deltoid muscle. Now it's time for range of motion. So I'm going to have to ask him to move, okay? Could you just do as I do, okay?
Yes.
Can you do this? Okay? Can you go all the way up?
It hurts a little bit.
I'm sorry, come down. Go to the front. Okay, then try your best to go behind. Okay, and I'll bring it back. Okay, and do this. Now, go this way. Okay, and this will help for external rotation. And come this way, internal rotation. Okay, so you can relax. Range of motion is done. Now, when you're examining a joint, you want to give consideration to the joints below as well. Okay, so I've done inspection, I've done palpation, I've done range of motion. Okay, I'm going to do that to the joint below. And then we're going to go into the muscle strength, the sensations, and reflexes. So, do you have any pain in your elbow?
No.
Okay. I'm just going to feel around, okay? Just real quick. Okay, no pain when I touch?
No.
All right. So I'm going to do range of motion. So can you just come up? Yes. down, okay, it's okay, up and down, it's fine. Now pronate and supinate for me, good, good. All right, any pain when you did that?
No.
Nothing, excellent. So you can relax your arm now. So I've done the range of motion of the arm. All right, so time for muscle strength, sensations, and reflexes. So could you do this for me? And normally on the exam, just in the interest of time, I'm doing it on one. Normally you won't do it on both. Okay. So can you pull? Good. Push. Excellent. All right. So put your arm to the side. Can you try your abduct?
It hurts a little bit.
I'm sorry. Adduct. Excellent. All right. Again, I'm going to do it with the other side. But just in the interest of time, I'll just, do it with one. Okay. So I'm now going, I've done the inspection, palpation, range of motion, muscle strength. So it's time to do reflexes. You're going to get a reflex hammer. Unfortunately, I don't have one, so I'm just going to make do with what I have. I'm going to check the reflexes. So you do this and you want to tap. It checks for the reflexes in the biceps. Okay, usually about C5, C6. All right. So, all right. So you see that he has this. This is around a 2+ on your exam. I'm going to demonstrate what, a 3+ and a 4+ possibly can look like. So he's going to, the reflexes will be hyper. So the patients on exams are paid actors, essentially. So when you do that, they're going to give you an exaggerated response, and their differential diagnosis to exaggerated reflexes. So just something like hyperthyroidism amongst many others. So I'm going to check the tricep reflex. So I'm going to have him, could you just, free up your arm, please? Some people do it a variety of ways. I like to do something like this and find the tendon and just go. So you see that as well. About a 2+, okay? So please. All right, so that is it for the reflexes of the upper limb, particularly the elbow. Then I can go ahead and examine the rest, okay? So I've done reflexes. It's time for sensations, okay? So could you close your eyes for me? Let me know if you feel what I'm about to do to you, okay? Can you feel that?
Yes.
Can you feel that?
Yes.
Is it same on both sides?
Yes.
Okay, was it sharp or soft?
Sharp.
All right. Can you feel that?
Yes.
You feel that?
Yes.
Same on both sides?
Yes.
Sharp or soft?
Soft.
All right. You feel that?
Yes.
You feel that?
Yes.
Same on both sides?
Yes.
Sharp or soft?
Sharp.
All right. You can open your eyes. Thank you very much. So that is the sensation as well taken care of. So remember, went through inspection, palpation, range of motion, muscle strength, reflexes, sensations. So I'm going to end at least that algorithm with the pulses. So I'm going to check his pulse. I'll be checking the radial pulse. So just put, I'm sure from your anatomy, remember where the anatomical snuff box is, somewhere around that. I feel good pulses, 2+, strong pulses actually. Okay, and you do that and you check. So that's how you go through the shoulder. And you can see that for shoulder examination, I went down to the elbow. I went down to the hand and checked the pulses. So you have to do that to get a complete picture of what's going on. Then we're going to end with the special tests. Usually each examination has a special test you want to do. So this special test can check for rotator cuff impingement or rotator cuff tear. We're going to start with the empty can test. I'm going to tell him to give me a thumbs up. All right, and thumbs down. Do you feel any pain when you do that?
A little bit.
Okay, so I want him to do NAC tests. So keeping his arm like this, I want him to take it up close to his ear.
Yes.
You feel
I feel
pain?
pain.
All right, you can relax. Then just relax your arm. Then for the Hawkins test, it's a bit, I won't call it too complicated, but you have to show them and give them directions. So I'm going to tell him to do as I do instead of just describing it. So can you do this for me? Okay, now can you do this? So as he's doing that, I want to help him. Okay, just free your arm. You feel the pain? All right, so relax, please. That's the Hawkins test. Okay, and then for rotator cuff tear, I want to check for drop arm tests. Normally, your deltoid around, up to this level, your rotator cuff helps you with movement, but the deltoid does the rest of the work. So if your rotator cuff muscles are torn, you cannot keep your arm horizontal at 90 degrees. So I'm going to have him just go up all the way. Thank you. Now, can you slowly drop? Okay, hold it right here. You can't.
No, I can't.
He cannot hold it at 90 degrees. So in this situation, I'm suspecting a rotator cuff tear. Okay, and that will mark the end of my exam. Something for you to know is that on the exam, if one special test is positive, you don't have to go doing the rest. Okay, it's enough to do one. If it shows you there's a problem there, you have the answer to that. Okay, so I'm going to ask him if he has any questions for me.
Yes, doctor. Do you think I will be able to ever get my arm function back again?
That's, I understand that you might be concerned about that, okay? Is a good question. Now, from what I have seen, I suspect it might be a rotator cuff tear. For now, I'll have to do some investigations to see if that diagnosis is correct. And if that's the case, after the necessary treatment and correction, yes, you should be able to get your arm function back.
Thank you.
Okay?
Thank you.